Welcome to another episode of Dr. Doctor, the award-winning radio show and podcast featuring your physician hosts, Dr. Tom McGovern
and Dr. Andrew Mullally, where we and our guests discuss relevant and health-related topics from an authentically Catholic perspective. Dr. Doctor is brought to you in part by CMF Curo. Learn more at mycatholichealthcare.org. Live your Catholic faith in your healthcare with CMF Curo.
Today, our guest will be heard across the EWTN Global Catholic Radio Network. Joining us again will be Dr. Paul Cieslak, infectious disease specialist, public health physician for the Oregon State Health Authority. He actually has expertise in the area of vaccinations, but we're going to talk about new viruses that are in the news, not spelled SARS-CoV-2. And in fact, I'm thinking of calling this episode Viruses in the News. Something old, something new, nothing borrowed. Should we be blue? And he's going to answer questions about that. But before we get to that, what makes this important to cover, Andrew? Viral diseases that are not the one we've been inundated with the last few years.
You know, I don't know if anybody else feels this way, but it's just the fatigue, the COVID fatigue. People are still talking about the COVID, and not to make it light, you know, I've been there too. It's very serious at times, but I don't know if I'm ready for the next pandemic. It's like having two vacations too close together. I mean, neither of them are fun. You just want to rest, you know? And
right.
The people are talking about the Monkeypox pandemic. I don't know.
There's no pandemic of monkeypox. There's no pandemic.
I'm wondering if all the news stations, they just got so many like canned things now that it's hard to get off the virus train. But yeah, I don't know. I'm not ready for the next pandemic myself, but it's in the news. We got to talk about it because people are saying, what's going on here? I had a guy not too long ago who came to me a little bit distraught. This was a week or two ago. Said, yeah, I went to this urgent care and they said I had poison ivy. Then they called me at home and said, no, I have monkeypox. I said, well, that person just got an email saying that you should watch for monkeypox and they remembered you. And sure enough, it was not monkeypox. No way, no. Jose. But the poor guy was scared to death. He's like, I don't know where I got it. And actually, that's one of the things we kind of wanted to talk about, Tom. You've done some digging because you used to be in biowarfare research, right?
Yeah, back in the early 90s, I worked at a place called the U.S. Army Medical Research Institute of Infectious Disease. And while we research infectious diseases, one of the main purposes for the military, not only to keep soldiers healthy and safe, but also to prevent harm from a potential biologic warfare attack. And so back in the 80s and 90s, they evaluated, could monkeypox be an agent? So back in 1997, the U.S. Army came out with its first textbook on medical response to biologic warfare agents. And then they came up with one again in 2018. And in the 1997 version, I actually was the first author on the chapter on plague, the Black Death, something you don't bring up in polite conversation at cocktail parties.
Is that why you dodge the cocktail parties, Tom?
I don't know if I've ever been to a cocktail party. So darn it, so I've never brought it up there. But anyway, that book had 2 paragraphs on monkeypox. And it was in the same chapter as smallpox, which has been eradicated from the planet because there's no animal vectors. All of the diseases, well, some of the diseases we're going to talk about, like monkeypox, have animal vectors. They carry it, so we'll never be able to eradicate it from the planet.
And people always were worried about smallpox because since it's been eradicated, so many people don't have immunity, right? So it could be a biologic weapon of some kind.
Right. And it can spread very well from person to person, probably better than monkeypox. In fact, that's one of the things this chapter said back then in the 2 paragraphs, was that clinically, it's often indistinguishable from smallpox. These little blisters that can become full of pus and kind of have a pressed in dimple in the middle, more on the palms, the head, and the soles than centrally on the body. And at that time, they thought that squirrels carried monkeypox, but it wasn't as easy to spread from person to person. Only about 30% would spread from one person to another. So it wouldn't maintain itself in a population like smallpox. So back in 97, they thought, not really a risk any country's going to use this. Then we come to the 2018 edition. I'm still writing about the Black Death there. Yeah, if you play a song well, keep playing it. But in this when I was looking yesterday at that edition, one of the authors of a chapter on taking care of biologic warfare um, patients is none other than Ted Cieslak, the brother and an infectious disease specialist, just like our guest tonight, Paul Cieslak. So we get to give a shout out to Ted, who I met while I was giving talks at USAMRIID. But in this,
Were
um,
they TED Talks?
always, always, he was cool before TED Talks were cool. So, what changes occurred in 21 years on monkeypox? Well, instead of 2 paragraphs, it got 5 paragraphs, and it said there was
Hmm.
one distinguishing feature with monkeypox was that you get really big lymph nodes in the neck, and less commonly in the armpits or in the groin. So more swollen lymph nodes with monkeypox, and there were sometimes it didn't look exactly like smallpox. It would be more limited than smallpox. And the U.S. had its first outbreak of monkeypox 19 years ago in 2003. But most of the cases, and at that time, there were 78 cases in the US, and 19 of them required hospitalization, and there were no deaths back then. But the cases since the 1980s, so in the last 40 years, have increased about 20 times in Central Africa, particularly the Democratic Republic of the Congo. So, and the fatality rate is worst among younger patients and among those unvaccinated. So those of you with the old smallpox scar, probably about 85% protection according to these textbooks against
Oh,
monkeypox if
wow.
you're exposed.
That's really good.
Yeah, I think that's pretty cool. So that's what we knew about monkeypox. And the reason I bring it up is, okay, what did we know about it before this? And how is that being introduced in the news? Does it look like a different disease? And we're going to let Paul Cieslak do that. That's his thunder, not ours.
Yeah, it's one of those things they're talking about it and people are always wondering, am I at risk? How is it transmitted? I don't think I'm at risk. Do I actually have to worry about this, or is this just kind of a symptom of nothing else more interesting in the news cycle?
And Paul's gets to answer those excellent questions, Andrew. But before that, our medical trivia question of the day, and the category is zoonotic diseases. So zoonotic, like zoology, refers to diseases that animals carry that humans can catch.
I
So
always said zoonotic.
it
You think
probably could
long
be
O
both.
there. I
Uh,
like it. It looks like
y-
zoo.
it does look like zoo. Zoonotic, then you pronounce each O. Zoonotic, whatever. They're probably variants, or I'm probably wrong.
No, you're
Whatever.
probably
I'm
right. I'm probably wrong, but I like it.
So, as I'm feeling generous, this question will be a multiple choice question. So, which of the following human infections is not considered a zoonotic disease? In other words, which of these is not an infection that initially or currently spreads from animals to humans? A. COVID 19. B. Lyme disease. C. Rabies. D. Plague. Or E. Influenza type B. We'll have the answer to this at the end of the show, but before that, we'll have Paul Cieslak and new viruses in the news here on Dr. Doctor. Welcome to our guest interview today with Dr. Paul Cieslak of the Oregon Health Authority, where he is the medical director for the Communicable Disease and Immunizations portion of the Public Health Division. He is a specialist in infectious disease. He has a lovely wife and family. He's been on Dr. Doctor before. Thank you for returning with us, Paul Cieslak.
My pleasure. Thanks for having me, Tom.
So this show, well, let's start with the something old. The something old that's actually new is monkeypox. And we're going to get into what's new about it. I already went through what's old about it, what we knew. So, Paul, ignoring the COVID pandemic, which most of us would love to do, are you surprised by the amount of coverage viral diseases have been getting on national news the past several weeks?
Well, it's been a lot, but I have to say, given the circumstances, no, I'm not surprised. People are generally very interested in health-related information. Even at baseline, if you watched a nightly news show, you would typically see several minutes of coverage about health issues. And when you have something new and exotic like this, and wow, it's spreading, and the World Health Organization has declared an emergency, it doesn't surprise me that people get interested.
Well, Paul, monkeypox was originally described in lab monkeys back in 1958, first human case in 1970. Before this summer, what was the extent of your knowledge about monkeypox?
Very little. There was an outbreak in the United States in 2003 in the upper Midwest associated with imported Gambian rats. And I remember learning about it a
Wait a
little
minute.
bit.
Why would anybody import Gambian rats,
I don't know why people would import
especially in the
Gambian
Midwest
rats.
here? Okay. Anyway,
Right. It was in the upper Midwest, and we learned that prairie dogs could be a reservoir for monkeypox. And I remember being horrified at the prospect of monkeypox virus being resident in the prairie dog population of the United States. I remember going through South Dakota once, and they had a prairie dog city, and I remember thinking,
yes, I've
"Oh
been
boy."
there.
Right. So I certainly didn't want that to happen and was relieved when the outbreak seemed to be extinguished.
Well, especially if they were co-infected with bubonic plague, the Black Death.
Well, rodents in many states of the United States, certainly including Oregon, carry bubonic plague, and we get a case or two now and then. New Mexico is the big
Yes,
epicenter for plague in
it
the
is.
United States.
It is.
Makes me appreciate how they used to name viruses like monkeypox. That's so much easier than SARS-CoV-2, 2019. Like it's in the monkey, it's a pox. We got it. So
Yeah, there's a long
we
history of naming things like that, or naming them after the location where they're first identified.
Yes.
see, there
Lots of
you
fever.
go. So I know, Paul, you're familiar with what we covered about monkeypox in the introduction, some of the history there. What has changed so that the World Health Organization declared monkeypox a global health emergency on January 20 or July 23rd rather of this year?
Well, the shortest way to say it is that it was being seen in large numbers in countries in which it hadn't historically been seen. It had traditionally been seen in Africa. There are two
Mhm.
clades of the virus, uh, in sub-Saharan Africa, and that's where we thought of monkeypox being associated. But when it broke out in Spain and Portugal and spread to other countries of Europe, that's what got people's attention. And then the other thing is that instead of being acquired directly from animals, uh, in this case, it was being clearly spread person to person and predominantly among gay men.
Yeah. So tell us some more about that. How is the transmission of this outbreak different than any prior outbreak? And how do you think that's being covered in the mainstream media?
Well, it's interesting, right? The previous monkeypox was usually acquired mostly among children who had contact with animals, infected rodents, sometimes eating bushmeat in Africa, and then occasionally there would be a case in a traveler or something like that. But in this case, we were seeing monkeypox spread among networks of men having sex with men, sometimes at big parties where people were having many sexual contacts in a given night, and the lesions, instead of sort of having a more widespread distribution through the body, were often on the genitals, often on the penis or in the perianal area, and that's very unusual and sort of bespeaks transmission during sex.
So,
How come this is not kind of on the news, so to speak? I had a patient come in, and he was shocked that someone thought he might have monkeypox, and he more said, I don't think I'm at risk for this. Of course, the provider at the walk-in clinic didn't think about that at all. The guy had a few lesions, ended up being poison ivy, but still, why is nobody covering this angle of it that many people might not even be at risk?
Right. I think there is a reluctance to come out and name a group as having an infection, a group that many in public health already consider marginalized, that is, men who have sex with men. And in addition, there is some skepticism that if we say this is being transmitted during sex, mostly among gay men, skepticism that gay men are going to alter their sexual practices. And then finally, because we in public health need to reach out to gay men in order to protect them, there's a desire to maintain good relationships with people in that community, with public health and the gay population, so that messaging, for example, around vaccination will be heard and acted upon. I agree in general that we should be, very explicit and just the facts, ma'am. And this disease is being transmitted primarily among gay men. It is true that susceptibility to monkeypox is universal. I mean, anybody could theoretically get infected if they had the right kind of exposure. Uh, but the fact of this particular outbreak is that it's almost exclusively gay men.
So
So
is monkeypox an STD? I mean, is it something that if you go to a baseball game and you're sitting next to somebody with monkeypox, could you get it there, or does it have to be more intimate than that?
Well, we think in this outbreak anyway that it has to be more intimate than that. Now, if you go back to where monkeypox originated, occasionally there was transmission within households. We know that it can be shed in the respiratory tract, that is in the mucus of the nose and throat. So theoretically, it could be spread by the droplet route, but we really haven't been seeing that. There is an occasional household contact in this outbreak that has been infected, but overwhelmingly it has been people who have had direct physical skin-to-skin contact with each other during the course of sex. I have seen some in public health trying to draw a distinction between a sexually transmitted disease, which they would define as being something where the virus or the bacterium is present in semen or in vaginal fluid. Uh, so sexually transmitted disease and sexually transmissible, that is able to be transmitted. I confess that I don't quite get the distinction. In fact, we think that this monkeypox is being spread in this outbreak basically the same way syphilis is spread. In syphilis, you have a chancre, a
oh,
skin
sure.
lesion on the penis or in the vagina, and during sexual contact, the genitals rubbing against that infected lesion, which is teeming with the bacterium that causes syphilis, Treponema pallidum,
Right.
and is spread to the skin of the next person. And so I think in this particular circumstance, monkeypox is largely being spread by that same mechanism, skin to skin contact during sex.
So, Paul, we remember about 40 years ago, we were just getting into medicine or college, an outbreak of another disease among men having sex with men. How is this monkeypox similar or different to the first reports of HIV back in the early 80s?
There are similarities because men who have sex with men were one of the primary groups that were affected. I would say the big difference is that HIV was also substantially bloodborne. So
Yes.
injection drug users who shared needles among each other, it's in the vein of one person, picks up the virus, goes into the vein of another person. There was a lot of spread that way.
Hmm.
And because of that, you know, it was in people's blood. Blood supplies could get contaminated.
Right.
And, at the time they were saying that gay men should not be donating blood. Uh, I recall that one of the big groups of people affected during the HIV pandemic in the 1980s and maybe even into the 1990s were people with hemophilia,
Yes.
because people with hemophilia lack clotting factors. In order to stop them from having big bleeding episodes or even bleeding to death, they would get regular injections of clotting factors, and those clotting factors came from the pooled serum of maybe a couple of hundred people, and they would need to get these clotting factor injections pretty regularly. So
Hmm.
ultimately, they were being exposed to the blood of hundreds and hundreds of people, and it was devastating to the
Yes.
population of people with hemophilia. I've seen estimates that 75% eventually succumb to
Wow.
AIDS.
Wow. So, Paul, do you think if the transmission of monkeypox today was different, that the World Health Organization would still have declared this an international emergency?
I think so. I mean, in a sense, this is a means of transmission that should be, easier to contain than, for example, respiratory droplet transmission. And we think that most of the transmission is happening while people have symptoms, so that there's not a
Ah,
big pre-infectious period of contagion, so that in general people know. That said, we're hearing that in this particular circumstance, a lot of the lesions can be small and mild and maybe even unrecognized. And so there is some potential for people to transmit before they know they have it. But not as much, I think, as with most respiratory droplet diseases.
What is the benefit of declaring such an emergency in this situation? What happens when somebody says it's an emergency? I mean,
Clearly they
I'm thinking of Michael Scott in The Office. I don't know if you guys ever watched that. He declared bankruptcy by just shouting it to everybody else in the office.
I declare it, yes.
I don't know if you declare this is an emergency. What does that mean? What happens now?
Yeah, well, clearly it gets people's attention, and including the attention of public health officials around the world and of policymakers who can allocate funding to try to address the emergency. I don't know whether WHO itself gets any particular additional authority. Their authority is largely based on their credentials. I mean, they collect the data for the world, and they have an eye to what's going on globally in a way that many of us don't. But I don't know whether they're getting an additional authority. I think it's mainly the public attention that's drawn to it.
So, Paul, our good friend Paul Carson texted me yesterday, knowing we were going to do this episode, and something about a Dr. Don Weiss, a public health officer in New York City, was abruptly transferred when he told his boss that suggesting in public health messaging that having sex while infected with monkeypox could be made safer, people avoided um, uh, and covered their sores while having sex. He argued that was unreasonable, that infected individuals should abstain for a time limit. Why would somebody like that be? Why would this be bad for a public health officer to do? What do you think was going on there?
Well, the obvious answer is that he, went askew from what his organization was mandating, and he kind of went out on his own and made this recommendation in an open letter to the New York Times. I happen to agree with a lot of what he said. I think that messaging should include, abstain from sex, certainly if you know you have monkeypox,
Mm-hmm.
because I do think it's pretty difficult to have sex while covering your skin. And so I happen to agree with that point. And an additional point, I would say, advice to gay men to at least reduce their number of sexual partners could go a long way toward reducing transmission, at least while we get people vaccinated. But basically, he was bucking the official policy of his agency, and it got him into trouble. But I agree with a lot of what he had to say.
So how serious would it be if somebody got monkeypox? If one of our listeners contracted it, what do they do? Is this a big deal? Is it a small deal? How should we think of that?
Well, there is the possibility for more serious infection spreading to the lungs, uh, but the vast majority of people seem to do well. In the New England Journal article that reviewed cases in several Western European countries recently, they said that 13% of identified cases were hospitalized. And the main reasons that they landed in the hospital was, first of all, for pain control. So these
Mm.
lesions can be very painful. And I've heard stories of men with a lot of lesions on the penis who could not urinate because it was so painful to urinate, or perianal
Yikes.
lesions, and they could not defecate for that reason. So that's pain control was the main reason for being admitted to hospital. And the second reason was what we call secondary bacterial infection. So if you're rubbing it or scraping it, and there's any break in the skin and the wrong kind of bacteria get in there, staph or strep especially, then you can develop a nasty infection from that. So those two things, pain control and secondary bacterial infection, were the main causes for hospitalization.
Well, and I see some stuff in the news about monkeypox vaccines. Is this something that people need to be thinking about, or only if they're, if they consider themselves high risk? How should we think about that?
Yes, I think it's really for high risk people, and in fact, there isn't enough vaccine to vaccinate everybody, nor would I think most people get any benefit from it. Um, we're targeting vaccine primarily at gay men and primarily at those who uh, have have sex with multiple people. So the strategy is to make sure that clinics that see patients with sexually transmitted diseases have the vaccine and can vaccinate people with sexually transmitted diseases. Um, People with multiple sexual partners, uh, HIV clinics tend to see a lot of men who have sex with men and sex with multiple partners. So those are really our target areas. There's some notion that laboratory workers who are being asked to test a lot of specimens for monkeypox may be another target for vaccination, and and there may be other occupational exposures, although I think most of us in healthcare have very little to worry about. We're usually wearing gloves when we're examining patients, and that recommendation should certainly be reinforced.
So, Paul, we've been talking about some practices here that, someone trying to follow the way Catholics want to live would not be doing. How do you speak to someone in public health who's trying to take care of people who are sick and yet live a life as an authentic Catholic?
Right. It's difficult when you're talking to people who don't share the Catholic faith and trying to convince them, especially if they have no grounding in Catholic morality. But obviously, for Catholics for whom sex is a sacred thing reserved to marriage between a man and a woman, they're only having monogamous relationships, and they are at zero risk for any sexually transmitted infection, much less monkeypox. Becomes a little more difficult to deal with when you're talking with someone who shares none of those
Right.
foundational beliefs, and you end up talking about protecting your health by reducing the number of sexual contacts. And I think most people can understand that. This is how sexually transmitted diseases are spread, and the more people you have sex with, the riskier you are. But if you're a Catholic living chastity as we're taught to do, you're not going to get this infection.
And on that note, we're going to take a break here on Dr. Doctor and be back with more in just a moment.
And we are back with Dr. Doctor, talking today to Dr. Paul Cieslak about all these viruses, not COVID, in the news. And so we are done with the monkeypox. Thank goodness, I hope. And he can't say anything for sure. Here we are. The next one is polio. So I was surprised to see an article not long ago that polio is making a comeback, both stateside in New York, but also in London. How can this be if the UK was declared polio free in 2003? In the US, I don't think we've had a case since 2013. What does this mean for polio to be coming back?
Right. It's actually very discouraging for public health people, because we were on the verge of eradicating polio from the globe, uh, 10, 15 years ago, and we were never able to close the deal. Uh, there remained spots within Afghanistan and Pakistan primarily, where polio kept circulating because it became very difficult to get vaccine into areas where there was a lot of conflict, and so the virus continued to spread. And then we had some of these. The oral polio vaccine is a live vaccine, a live attenuated vaccine. We've long known that occasionally one of the strains in the vaccine can revert to a virulent form and cause paralytic polio. They call it vaccine associated paralytic polio. And in the United States, back in the year 2000, we stopped using the live attenuated oral polio vaccine, OPV, because of that occasional case of vaccine associated paralytic polio. The estimated risk for that was about 1 out of every 2.4 million doses. It's a 3-dose series in childhood, so it was usually the first dose that caused it, and it was about 1 out of every 800,000 first doses administered. But we had had no polio in the United States for some time, and therefore, we decided to stop using oral polio vaccine and start using the killed inactivated polio vaccine, and we got rid of that risk. But other areas of the world were still using the oral polio vaccine, and they started having circulating vaccine-derived polio virus, and
Mm.
so that's actually one of the main causes worldwide. And because we never closed the deal, the viruses are still out there, and they can, travel across the globe on an airplane flight, and then be spread to anybody who doesn't have immunity. And not everybody was vaccinated. There is some susceptibility, and immunity wanes over time. And so we can see polio still, even in developed countries.
So, Paul, is it of concern whether or not somebody has this vaccine associated polio versus just the wild type polio that was never in a vaccine? Or doesn't it matter?
Well, I don't think it matters too much. If it has reverted to a virulent strain, then it is dangerous.
Okay.
The way you stop it is the same way as you stop the wild type. You vaccinate people against
Okay.
it, and then they're going to be immune to it.
So, what do we know about this New York outbreak, and what's the big deal about sewage and viruses?
Well, my understanding is that they just have a single case in New York,
Right.
in a county adjacent to New York City, and so a single case. But the wastewater testing that they're doing has demonstrated that there is some circulation of poliovirus within the city. Now, remember that only about 1 in 200 people who's infected with poliovirus is going to come down with paralytic polio. It's the rare person. Most people just have no illness or have a milder illness. So there may be other infected people out there who didn't get paralyzed by it. The wastewater testing is very interesting. We started doing it in Oregon with COVID-19 because we got funding to do it, and we started testing wastewater around the state. But it's a way to test thousands of people at the same time, right? Because all the
Sure.
wastewater goes into a single place. And with the very sensitive nucleic acid tests that they have nowadays, they can detect very small quantities of it, and you're essentially testing a population. And it's not doesn't have to be the population that gets sick. So you can find people without symptoms who are putting it into the waste stream, uh, or people who don't go to the doctor and get tested. So this is a way to detect it, even if it's not showing up in clinical medicine. So it really holds some promise. Finding it in wastewater, though, does not mean. I mean, the wastewater is low risk. We do not see wastewater causing illnesses in developed countries. Whenever there's a disaster, I get questions about, well, do we need to vaccinate sewage workers against hepatitis A or against
Ah,
tetanus or
sure.
against any one of a number of diseases? And the answer is no, because it's so diluted, in the waste stream that it really doesn't pose a risk to anybody. So that's not a concern, but it betokens some spread somewhere within the population.
Okay. And I understand this area where the polio is maybe circulating out north in New York. It's kind of an Orthodox Jewish community. It's kind of a tight knit community. Have we seen other diseases spread in tight knit communities like that?
Yeah, yes, we have. I mean, I remember, for example, a measles epidemic that primarily hit an under-vaccinated Amish community in Ohio. Turns out that they didn't really have anything against vaccination, but they did not have a lot of contact with modern medical systems, and so they weren't getting vaccines that others are recommended to get. Similarly, in the Orthodox Jewish community. There was a certain amount of opposition to vaccination, or skepticism about vaccination, and they have had measles outbreaks and mumps outbreaks in the Orthodox Jewish community in New York City. So it isn't terribly surprising.
Well, and I think with the recent pandemic, there's been somewhat of a shift on vaccination rates. I know Andrew's mentioned to me in his office it seems to be down, but do you have any numbers, Paul, on how childhood vaccinations are going now anywhere in the country versus pre-COVID?
Right. A lot of places, just about everywhere, saw decreases in rates of routinely administered vaccinations, because during COVID, people were encouraged, not to be in places where lots of other people were, so people weren't going to their routine doctor appointments for a long time, and vaccination rates dropped. Um, One study, for example, found that of the diphtheria, tetanus, pertussis series, you're supposed to get this vaccine at 2 months, 4 months, and 6 months of age. Everybody's supposed to get it. Globally, the World Health Organization said there was a 5% drop in kids getting that routine series. WHO estimated that 25 million infants had missed out on vaccinations during the COVID-19 period. Some studies in the United States came up with sort of similar trends. A study was produced in Michigan in the year 2020 saying that the children 5 months of age who were up to date with all their recommended immunizations went from about 2/3 of kids that age during 2016 through 2019, the pre-COVID years, to about 50% in May of 2020. So a significant drop in those infant vaccination rates. And then another study looking at several hospital systems around the country said that in September of 2019, 81% of US kids at 7 months of age were up to date with their shots. That is, they got everything recommended at 2, 4, 6 months of age. Mm-hmm. 81%. But by September of 2020, that number was down to 74%. So, we're looking at 5 to 10% decreases in infant vaccination rates, and we know that some of those kids will never catch up.
Well, and Paul, one of the things that's been really concerning for me to see among my patients is that after COVID, I had folks who are still coming in for visits now, and they were previously vaccinating, and they've elected to discontinue vaccines because, I don't know, I think they're just really uncomfortable with the whole COVID and COVID vaccine and the relationships that some of them have to the aborted cells. Do you see that nationwide? I mean, I feel like in our community, we might see more of these breakout diseases.
Yeah, you may be seeing it earlier than they're showing up in national data. I am concerned about that possibility. I think I'll have to wait to see more data on what's happening in infants, for example, in the year 2021 and 2022 to see if there's a rebound from that. But that would be very disturbing if we started to see a lot more people refusing vaccinations. I'm already worried about, us being on the cusp with measles, because measles is, one of the most highly transmissible diseases, and you really need very, very high vaccination rates, upwards of 95% to keep measles from spreading once again in the United States. It really doesn't spread now because of vaccination rates. You get a case or two, but it peters out. But if we drop, even 5%, I think we'll see sustained transmission of measles in the United States.
And what would be
Wow.
bad about that, Paul?
Well, we would have to undertake public health measures to try to control it. But even in developed countries in recent years that have let their vaccination rates sag, you see a mortality rate from measles that's something like 1 in 1,000. And if we see tens or hundreds of thousands of cases where we will see people dying of measles. Those diseases are still around, and until we eradicate them, we'll be susceptible if we don't maintain our vaccination rates.
Well, let's go back to polio. You've already clarified that the people most at risk are in communities where there's a lower vaccination rate. And it seems like it doesn't have to be as high a rate as measles, like you said, 95% or more. Here, what is it, around 70% to have some kind of community-wide protection. But how is polio spread? I mean, is this another disease like COVID that can be respiratory, or like TB, or is it different?
It's quite different, actually. It's what we call fecal oral spread. So listeners, brace yourself. There are a lot
My
of
wife loves that term.
yeah,
I'll bring it up sometimes, and
yeah.
she's just, ugh, you know.
Yeah, there are a lot of pathogens that, viruses and bacteria and parasites that live in the intestines of human beings, and they don't seem to have too much trouble getting into the mouth of another human being, and that's how the diseases are spread and sustain themselves through the centuries and millennia. And poliovirus is one such virus. Um, but that means it's harder to spread than, say, COVID. It's not like getting coughed upon. It requires a breach in hygiene, people who aren't washing their hands after using the toilet. Uh, uh, but swimming has been associated with it. For example, if you've got toddlers in the swimming pool, they may have an accident, and
Mm.
whatever they have is traveling around the pool, and people can get exposed that way. In the early 1950s, when we had big epidemics of polio in the United States, parents were afraid to let their children swim in public pools for that reason. So it spread through that route, and it is more difficult to spread that way, but able to sustain itself.
So, with just to clarify one thing as well, with the current polio vaccines in America, is there a risk of still getting polio?
Yes, there is. And here's the problem. When you got the oral live attenuated polio vaccine, the kind that came with a 1 in 800,000 risk on first dose of having a vaccine associated paralytic polio, you got pretty durable immunity. But with the inactivated polio vaccine, the series of 3 injections that you get during infancy and toddlerhood, uh, the immunity is not so durable. Your antibodies wane over time,
Ah.
and yeah, and we think you need those antibodies in order to protect yourself against polio. Several years ago, I want to say it was 2012 or 13 or so, the recommendation was made to add another dose of inactivated polio vaccine during the preschool years to kind of boost kids before they went off to school. But immunity from that will probably wane as well, and we may be left with cohorts of adults who are once again susceptible to polio. So that's not a problem if you don't have polio circulating. And I would like to remind your listeners that because of vaccine, polio was eradicated not just from the United States but from the entire Western Hemisphere back around 1994. So even the developed countries, the very poor countries, where hygiene, was not what it is, where sanitation isn't what it is here, we're able to get rid of polio through vaccination. But now that we're on an IPV schedule, we're going to have some susceptibility again.
All right, in our last
Wow.
5 minutes, we want to cover a couple other diseases. Just one question. There's a new virus out of China, which has been transmitted apparently from shrews called Lyme virus. What should we know about that?
Probably not too much. I don't see it as a big threat. This is a virus, right, that seems to be transmitted from shrews to human beings, but is not spread person to person, and for that reason, unlikely to catch fire within human populations. Moreover, I'm only aware of 35 cases that have occurred in China, and no mortalities associated with it. So.
So, what
Uh,
other
the
viruses should we be aware of, Paul?
Well, viruses are coming and going all the time. I would say one of the big ones on our radar screen is dengue virus. So, this is a mosquito borne virus that has been prevalent in tropical countries, including in the Caribbean and in Puerto Rico. And it's transmitted by a mosquito called Aedes aegypti, and also to a lesser degree by one called Aedes albopictus. Um, well, we have Aedes albopictus in the southeastern United States, so we have a competent vector, a transmitter of this
Okay.
virus in the southeastern United States. Dengue has been growing worldwide, and it may be a function of warming weather, longer periods of mosquitoes being active and biting, and of course, the more biting they do, the more infected people you have, and then the more infected people you have, the more it can spread when the mosquito bites one person and goes to another person. I learned in my infectious disease training that a traveler to the tropics who's coming back from the United States who has a fever, The most common cause is dengue virus. Now, the one we really worry about is malaria, because that's one that is more likely to be lethal and that we can treat. We have
Right.
anti-malarial drugs. We don't have any good treatment for dengue, so you could diagnose it, but you couldn't treat it. But dengue was the number one cause of fever.
Is there a good vaccine for that?
Well, there is a vaccine that's come out. It's recommended for a small group of people, which is basically kids who have already developed antibodies to dengue virus, and basically in territories of the United States where it's circulating. So pretty much Puerto Rico and Guam, and it wouldn't be recommended for other Americans. And the reason that they have to have antibodies against it is that if you develop, I'm sorry, people without antibodies against it, because if you've had one dengue infection, this is a live attenuated vaccine, and if you've had one infection and you get infected then by dengue serotype 3, there are 4 types, 1, 2, 3, 4, then you could get a really bad infection called dengue hemorrhagic fever. This is from antibody-mediated disease enhancement. So it's a really small group of people that would qualify for the vaccine.
So, in our last minute or so, Paul, what key lessons can we as Catholics learn from these recent outbreaks?
I would just say that diseases. There's a lot of viruses and bacteria out there. We're used to seeing certain ones, but when we change anything, and we're changing constantly, we're liable to see new ones cropping up. It's become very popular in the West to live in high desert areas. Well, high desert areas are prone to getting hantavirus infection. If we change our eating habits and start eating more alfalfa sprouts, we saw big outbreaks associated with salmonella and E. coli 0157 with alfalfa sprouts. Reforestation has been going on in the United States for decades. That means more deer. Deer carry ticks that carry Lyme disease. So we've seen more Lyme disease in the United States. So change is constant. We're constantly going to be finding new stuff that crops up or old things that increase. And, we need to have systems in place to detect them, to figure out how they're being transmitted, and to take measures to stop them.
Paul Cieslak, that was wonderful. Thank you so much for being with us again on Dr. Doctor. I suspect we'll see you again in our future.
My pleasure. Thanks.
And we are back with Dr. Doctor and the answer to the trivia question about zoonotic diseases. Tom, what do you got?
All right. Which one of the following 5 diseases is not spread or was not originally spread from an animal to a human being and then started circulating among human beings? A, COVID-19, B, Lyme disease, C, rabies, D, plague, the Black Death, or E, influenza B? And Andrew, I'm sure you were all over this one.
I did. I knew this one. I was really happy. Whenever I get yours, I'm always a little surprised and really happy. So the answer was E.
Influenza B. So the current vaccine against influenza includes A and B. And influenza A actually was originally from other animals like swine, like pigs. But influenza B is only between humans. COVID-19, we know it started in either bats or pangolins or something else in China. Lyme disease, Paul Cieslak mentioned, this tick that lives on deer primarily carries it. Rabies, of course, we're well aware where that comes from, mostly dogs. And then plague, fleas that live on a number of different small and medium-sized mammals. But in the Black Death was the black rat. So, Andrew, we heard a lot from Paul about new diseases. What are your top 3 takeaways from this interview?
Yeah, I guess number 1 would be in regard to the monkeypox. The punchline would be to practice chastity, and you will not get monkeypox.
Amen to that.
That's pretty much
simple. Yeah.
If you're doing that, you're not going to get monkeypox. So that's a blessing.
And we apologize for talking about some things that aren't too comfortable, but it's good to know the truth about this, that the vast majority of people are not at risk for it. Now you know.
Yes, thank goodness. And number 2, I guess, in regard to polio, the punchline is that polio is spreading. They commented on 1 case in New York, but the evidence, as Paul was kind of mentioning, suggests that there is a group spread 1 in 200 people get paralyzed. So that leads me to point number 3 is if you've fallen behind on the vaccines, I'd really consider getting vaccinated, especially with these diseases. At least in my estimation, unfortunately, we're going to probably see more of these as people get less comfortable with vaccinations. People miss more doses and don't think much of it. That's when these diseases come back. And so if you're not up to date, I encourage you to make an appointment, get up to date.
As we covered a couple years ago, the company Sanofi Pasteur, which made a lot of the polio vaccines, stopped producing their vaccine made in cells from aborted fetal tissue, and they're now made in animal cells and completely ethical. So this is a very good thing. You can now easily get polio vaccine that has no relationship to abortion.
Well, and Tom, you probably see patients too who had paralysis from when they were a
Yes.
kid and they got polio. And I see those folks too. So it's just something I hope never comes back.
Amen to that. Hey, thanks for listening to another episode of Dr. Doctor. You can find this episode, all our old episodes on our website, drdoctor.org. Just click on episode archive near the top and you can search over 280 episodes by either guest or topic.
And if you didn't know this, we have a video version of our podcast. This would be a great episode to listen to on video because Paul Cieslak has a dandy bow tie. And so you should just click on the YouTube link at the top of the drdoctor.org homepage. And if you have any good ideas for a show, click where it says submit a question. Give us a good idea. We're into good ideas.
This is Dr. Tom McGovern
and Dr. Andrew Mullally, and we're signing off until your next dose of Dr. Doctor.